I'm Dr. Wende. I'm a senior pain physician in Hadassah Hospital in Jerusalem, and I lead the treatment of the musculoskeletal pain in the pain unit. I want to talk to you today about the principles of musculoskeletal evaluation of the joints. And I think that today this is so important as we're living under so much pressure, we work under so much pressure from all corners to try and get through as many patients through in as short a time as possible. And this comes at the expense of taking a thorough history, of doing a thorough physical examination. We're relying more and more on technology, on ordering CTs and MRIs, and basing our diagnosis on CTs and MRIs and other tests, which are not always relevant to the patient's diagnosis. We miss out on a lot of cues which can pick up on from a proper physical examination, from looking at them, from palpating them, from moving them. And I'm going to present some of these to you in this talk. So the aim of this lecture is to present some sort of system that you can apply to the examination of every joint. And this can help you classify pathologies into arthritic problems versus tendinous and ligamentous problems. This system is not meant to replace the specific tests that we use for each joint, whether it's the McMurray's or the Jobs or the Lachmans, but rather to complement them. And together, you can very often arrive at a fairly accurate clinical diagnosis and get right on target. So a knowledge of basic anatomy and biomechanics is necessary in order to evaluate the patient clinically and to work out a diagnosis. You have to know what you're examining, what you're looking at, what you're moving. So when we start our clinical evaluation, we actually start with inspection before the patient opens his mouth. This inspection often starts even before the patient walks in. You can often hear what happens outside, how the patients are communicating with the secretaries and the nurses. Is there any friction going on there? You take note during the examination when the patient walks in, how the patient walks in, what's his gait like, his posture, his general mobility. Is he relying on any aids to walk in? You're also noticing his mood or her mood, interactions with the people around, with the people who are accompanying him to the clinic. And an overview of all these factors gives you an inclination of what the coping strategies are like. And this is so important because if the patient does not have good coping strategies, his response to treatment is going to be very much suboptimal. And the assessment of all these is is continual throughout the whole consultation. So very quickly, taking note of the pain history, you obviously first ask for the age and occupation if there is, if the patient's working at all. And we use a mnemonic, OPQRST. This is taken from Bonnecker's Management of Pain. That was our textbook for pain medicine. So O represents onset. What's the onset of the pain like? Was it sudden, as in after a fall or trauma, or insidious? P stands for precipitating factors or perpetuating factors. Is the pain worse when the patient walks, stands, sits, changes position? Are there perpetuating factors like poor ergonomics, poor sittings, poor working environment? How does he sleep? What position does he sleep in? Q stands for quality. What's the pain like? Quality of the pain. Is it a pressure, compressing sort of pain? A heavy sort of pain, which may indicate a musculoskeletal or mechanical sort of source of the pain? Or is it a burning, electrical or shooting sort of pain, maybe accompanied by paresthesias, which indicates some sort of neuropathic pain? R stands for region, radiation or referral. Where is the pain and where does the pain refer to? S stands for severity. You assess that on some sort of pain scale, whether it's an NRS or a VAS score. So you can't obviously compare the pain level between one patient and another because everybody has different pain thresholds. but you can compare pre- and post-treatment scores. How did the patient fare from a treatment? Did he get better or worse? You can also monitor a patient throughout a disease, throughout a malignant disease, for example. Is the pain getting worse? S can also stand for sleep, and this is very much neglected when we're taking a history, because we all know that patients in chronic pain suffer from sleep, don't sleep well, but we also know that patients who don't sleep well have much more pain. And T stands for timing. I'm not referring to the timing whether it's worse with sitting and standing and walking, because that's the precipitating factors. But is the pain worse in the morning or in the evening, in the winter or the summer? And then we want to look at the associated symptoms, red flags, which are really critical and important to rule out. Are there systemic symptoms? Is there a fever, loss of weight, loss of appetite? Night sweats? Is there a change of mobility, which may be sudden? Is there a progressive, unrelenting pain? And you want to find out about joint involvement, other joint involvement. Past history. You look at, the main thing is the most important thing is to find out about malignancy and fractures. And these have been found to be the most significant factors in red flags, amongst all the red flags that can be looked at. Medications. Is the patient or was the patient taking steroids? Is he on statins, which can cause muscle pain? Chemotherapy, which can cause severe neuropathic pain, amongst a whole host of other symptoms. And we want to find out the patient's analgesia. So we all know about the red flags, but not many of us have heard of the yellow flags. These indicate some sort of psychosocial element going on. Is there depression, anxiety? Are there social problems? Are there marital problems? Is the patient unemployed? Is there drug addiction? And the presence of any of these yellow flags indicate some sort of pathology which is going to slow the prognosis and definitely impair the response to treatment. So we must address these yellow flags if we want to have some sort of success. So we've talked about the inspection of the patient when the patient walks in, and even before he walks in. We notice his mood, his interactions, and etc., and his gait and mobility. And this is a continual reappraisal right throughout the consultation. We're looking at the posture. And ideally, we should undress the patient at least halfway, at least once during the course of all their visits. I know that it's impractical to undress every patient every time throughout the treatments and to undress every patient during the day. It's not practical in our lives, but at least once. We can pick up so many signs, and I'll show some of these in the next slide. So we're looking at the kyphosis, the lordosis, the pelvic tilt. Does the patient have a forward head posture or forward body posture, which the latter may indicate some spinal stenosis or a short and contracted psoas muscle. We're looking at symmetry of various structures, of the shoulders in their are they symmetric in their height, scapular alignment, the height of the iliac crests, the knees, are they in genovarus or valgum? And we want to look at muscle wasting. Is there a generalized muscle wasting or a localized muscle wasting? So here are some pictures of patients of mine through the clinic. And I want to show these and sort of point out some clinical signs that you would never pick up if you don't undress the patient, at least partly. So the top left-hand picture is of a 45-year-old lady with right scapular pain. And you can see that the right shoulder and the right scapula is lower than the left. You can also see that both scapulae are slightly downwardly rotated. And you could also see where I've got the arrow pointing to a sort of a taut band in the rhomboids muscle. And this patient indeed did have very active trigger points in the rhomboids, which were successfully treated with dry needling, giving lasting relief. The picture on the lower left is of a 28-year-old guy who bent down on the oblique to pick up something, And when he uprighted himself, he was in such a severe spasm, and he was virtually immobilized for the next 5 weeks or so when he came to me. And this happens quite notoriously from bending down on the oblique to pick up something, and is very often due to a strain of the quadratus lumborum muscle, which is very vulnerable to strain when one picks up something from the oblique, or even bends down without even picking up anything. So this was treated with dry needling of the lower back muscles, the multifidus and the rectus spinae, but also of the quadratus lumborum, and that gave him lasting relief. The top middle picture is of a guy with right shoulder pain for 3 years. And you can notice that the right infraspinalis muscle is atrophied. You can also note that the supraspinalis muscle is not atrophied. So this could be due to one of two causes. There may be a suprascapular nerve neuropathy due to some sort of entrapment, local entrapment on its way from going from the supraspinalis to the infraspinalis. Or there may be a full thickness rotator cuff tear of the infraspinalis muscle, of the infraspinalis tendon. And this guy did have a full thickness tear of the infraspinalis tendon. The picture in the bottom middle is of a guy where you can all see he has a very obvious osteoarthritis of the right knee. You can see bony deformities and osteophytes, and it's sort of bony and enlarged, but you can also see that he has quite an obvious genovarus deformity. Now, this is important to pick up even if you're not even if you're not treating the knee, because this patient is going to put more weight on his left lower limb, his right knee is not shock absorbing properly, and his ankle and his hip and even his sacroiliac joints are going to bear more of the brunt. In the picture on the right-hand side, you can see a picture of a lady with of the groin area. And what's interesting to note, you can't really see it so well in the picture, but you can see that this patient had some sort of very superficial swelling, edema of the subcutaneous tissue, even of the dermal tissues, just around the groin and the upper medial thigh. And she had a lot of allodynia there. She really couldn't touch that. And I treated that with a block to the medial cutaneous nerve of the thigh under ultrasound, and this gave a lasting relief. But if you don't look at those signs, if you don't undress the patient, you don't pick up on these cues, and you miss out on so much. So these are just some examples to show how undressing the patient and looking for signs can give you so much information. So we want to introduce some sort of method that we can differentiate between the various problems, between the different pathologies. We've got a lot of structures to test for, and we want to be able to work out the diagnosis. So we're going to bring some sort of system that we can work this out. So we're using selective tissue testing. So we've got lots of different structures to test for in the joints. We've got the non-contractile structures, which include the joints and the bones, and the bursae and the ligaments. And the contractile structures, which include the muscles, and the tendons aren't really contractile, but they're connected to the muscles and they're affected directly by the contraction. So we're going to classify that as a contractile structure. With selective tissue testing, there are 3 movements. There are active, passive, and resisted movements. And we don't have to use every movement in every patient all the time, but every movement gives some sort of clue to a diagnosis. The active movement test gives us some inclination to the willingness of the patient to move, the amount of pain that is in, and if there's any neurological problem. If there's a large disparity in the range of motion between the active movements and the passive movements, then that can give us a hint to one of three problems. Either there's a neurological problem, in which case there's not usually much pain associated. The second possibility is that the patient's in a lot of pain due to some sort of contractile structure. If he's got a problem with the muscle or the tendon and he's going to activate that muscle, that's going to cause him a lot of pain, for example. And he may have a large psychosomatic component or fear avoidance behavior, which is the problem with the pain but taken to a further extreme. And remember, the gait is also an active movement. Passive movements, the aim of the passive movement is to measure the range of motion of the joint. That's the primary aim. So we want to find out if the joint has a pattern of motion that suggests there is some sort of arthritic problem or a capsular problem. But also, not only that, not only do we measure the range of motion, as soon as we start moving that patient, as soon as we start moving that joint, we want to try and get a feel of what that motion is like. Is there any resistance? Is the patient with me or is he resisting me? And if he's resisting me, is it a neurological problem? Like, can you pick up, you may be able to pick up if there's cogwheel rigidity or spasticity, which may suggest an upper motor neuron lesion, or the cogwheel rigidity will represent a Parkinsonian problem. So each joint has its own pattern of limitation of motion, in that there's one motion, usually one motion, that is limited first if the problem is arthritic, or if you want to call it capsular. And when you're checking for the range of motion, and you started to get the feel of what the motion's like as soon as you start moving that joint, when you take that joint movement to the end of range, you also want to take note of what the end feel is like. At the end of range, what does it feel like? Is there bone touching bone? Or is there a bit of negotiation? Is there a give and take? And if there's a bone touching bone sort of movement, sort of end feel, that would suggest that there's an end stage osteoarthritis or an ankylosing spondylitis. So I'm just going to run through a few examples of joint movements, of what the patterns of each joint are. Okay, so we'll start with the knee. The knee has basically two main movements. If I take the hip into 90-degree flexion, I'm measuring flexion to the end of range and extension. Now, with the knee, the movement that is most limited first, if there is an arthritic problem, is flexion, is this one. By the time extension is limited, we're pretty late in the stage of the disease. With the hip has 6 movements. There is flexion, extension, which would go this way, behind, abduction, which I'm going to, okay, that's abduction, adduction, and to test internal rotation, best to bring the hip to 90 degrees. This is external or lateral rotation with the knee pointing out, and internal rotation with the knee pointing in. By the way, your internal rotation is a little bit limited. So this is internal rotation, and this is the movement that is most limited when there is a problem with the hip joint. The elbow basically has 2 main movements. There's flexion and extension. There's also supination and pronation. This is supination and this is pronation. The movement that is most limited when there is an arthritic problem in the elbow is flexion. The wrist is a tricky one. The wrist has extension movements, flexion, radial deviation, ulnar deviation. If there is an arthritic problem in the wrist, the one that is most limited is actually not one, but there's two. Is flexion and extension, and flexion to an equal range. In other words, they're proportionally the same. If this is baseline and extension goes to, let's say, 40 degrees, then flexion will go to 40 degrees. So if someone has an extension to, let's say, 90 and flexion to 40 degrees, that is not an arthritic problem. So the shoulder passive movements, there's 6 movements of the shoulder. We have flexion up to 90 degrees. There's a tiny bit short of that. Okay, extension. Abduction, which should, here's a little, one second. There we are. Okay, so that's abduction. Adduction is here. And then we have medial rotation. We can test, it's this way, but we can test it up to going to the back. Or I'll just show this side. And we want to see how far he can touch, how far he can get up to his, and touch his back, how far up, and compare that to the other side. And lateral rotation, this is lateral rotation. It should get to 90 degrees. This is a tiny bit less. That's quite normal for his age. But this is most limited if someone has an adhesive capsulitis. This is the one that's most limited with an arthritic problem of the shoulder. So once we've come to a diagnosis that the patient has an arthritic problem, the problem is in the joint, then we have to decide what that problem is. And there's a differential diagnosis here. So does the patient have a degenerative osteoarthritis, or an inflammatory arthritis, or a septic arthritis, or is there a hemarthrosis, or maybe just a large effusion that's limiting joint movement? So that's in terms of a capsular or an arthritic joint range of motion. But what happens if the limitation is not of a capsular pattern? Let's say someone has limitation of abduction of the shoulder much more than lateral rotation. So you have to ask yourself, what structure is limiting the range of motion? What's going on here? Is it with the shoulder, for instance, is it a rotator cuff tear or a tendinitis or a bursitis? If someone, let's say, has a limited hip extension first, more than anything else, then you would think maybe that person has a short psoas muscle, iliopsoas bursitis, or even trigger points in the back in the psoas muscle, which is limiting hip flexion, hip extension. And if, when you're checking the joint motion, you notice that there's a motion that is excessive in range, there is excessive, for instance, inversion of the ankle, then one suspects that maybe there is ligament laxity or a ligament tear. Or for the knee, you look for the Lachman's test. And now we're coming to the resisted movements. The purpose of the resisted movements, first of all, it's part of the neurological examination. But we want to decipher if that pain is emanating from a contractile source. So we want to see if that pain is elicited by activation of the muscle or the muscle that attaches to the tendon that's in question. Now I want to bring home an example that's easy for us to all understand, to comprehend. That, let's say we're on a football field and you get hit really hard in the gastrocs. And those gastrocs swell up. Within an hour, there's a huge hematoma swelling there. And you're going to be limping around. And if you ever try even stepping on your toes, that's going to hurt. So you could understand the gastrocs is contracting, it's going to hurt. But let's say you don't have a hematoma in the gastrocs, but you have an acute Achilles tendonitis. And you go to your doctor, and your doctor asks you to step on your toes. That's going to really hurt, because the gastrocnemius and the soleus are pulling on that acutely inflamed tendon. So we can understand with the gastrocs and the soleus, this is peripheral, we can all feel it, we can all see it, we can all see it connecting to the Achilles tendon. What's going to happen if we pull on that Achilles tendon? But when it comes to the shoulder or the hip, we've got muscles going in all different directions. It's more complicated for us to understand what's going on. We can't sort of visualize it so well. So this is why we test the resisted movements, and we want to see what resisted movement elicits the pain that the patient suffers from. Now, with the shoulder and the hip, the muscles overlap in their function a bit. But we want to see which movement is the main movement that elicits the pain. Okay, so now I'm going to test the resisted movements of the different joints. Okay, so we talked about, I gave the example of testing the gastrocs and the soleus, standing on your toes, but you can also do this with the patient lying down. So push down against me, and I want to see if that elicits any pain that the patient has. Standing on the toes obviously puts a lot more pressure and weight on the tendon, so that is likely to elicit more pain. If I want to test the quadriceps or the patellar tendon, or the quadriceps expansion, or see if there's any trigger points in the quadriceps muscle, then I want to test the resisted knee extension. So, resist me, straighten your knee. That's it. Good. Do it again. Very good. Okay? The hip. The only muscle that flexes the hip beyond 90 degrees is the iliopsoas. So if we suspect any iliopsoas pathology or any muscle pathology or psoas pain in the back, or iliopsoas bursitis or a tendonitis, then this is the test we want to do. So I brought the hip into 90 degree, up to 90 degrees hip flexion, and I'm going to ask the patient to pull his hip towards his tummy. And I have to be as strong as him, okay? So that's it. So that's, okay. I'll do it again. One more. So that's resisted hip flexion. We want to test the gluteal muscles. The gluteal muscles, especially the gluteus medius, can cause pain referring right down the leg, even up to the ankle. The gluteus medius is notorious for causing pain around the trochanteric bursa and down. In fact, most of the cases of trochanteric bursitis are not really bursitis. 80% are due to a gluteus medius tendinosis, not even a tendonitis. There's no inflammation there. So we can test the gluteus medius with resisted abduction. Push out against me. And I would like to test both sides. Push out both. Okay? And you can do this with a patient prone. You can do it or supine. You can also do it with him lying on his side, but that's a little bit more complicated because you have to make sure that he's sort of in a perfect side lying plane. Okay, so that's the hip. Tennis elbow. We want to make sure, see if the patient's got a tennis elbow. We want to test the wrist extensors in resisted movements. So push that against me. That's right. Okay. If I want to test for a golfer's elbow, then I will test resisted flexion, and best to do it, 1 second, best to do it with the elbows straight. Do it again. Okay, and again this way. Just resist me. That's it. Very good. Okay. So that's the elbow. That's the wrist. Elbow, we want to test the elbow against resistance. That's the biceps. And then we'll have the shoulder. So we're testing for the muscle's main function and to see what causes the pain and to see where the pain is most dominant. Okay, so for instance, okay, I'm testing now the supraspinatus. Push out against me. Okay, he's stronger than me. Okay, when testing lateral rotation, I want to make sure that his elbow is right abutted by the loin when he's pushing out. So push out against me. Okay, because if it's not abutted by the loin, then he's going to be doing something like that. Push out. And then he's mixing both abduction and lateral rotation. So to be sure, make sure he's butted and push out. So that's resisted lateral rotation. That's testing the infraspinatus. Subscapularis, pull towards you. Okay, or we can do the lift-off sign. You turn slightly this way and put your hand back behind, and now push back, push me back. Okay, that's a much more difficult test to do. It's more challenging, but that's testing the subscapularis. And we know all the biceps does elbow flexion in supination, so we want the elbow supinated, and we're testing resisted flexion. The pain can arise from either the muscle or the tendon. And in order to arrive at the diagnosis, which is the problem, then we have to palpate the tendons and the muscles. And that I do at the end of the treatment. Because if you have, at the end of the examination, because if a structure refers pain peripherally, then that point peripherally may be more tender. So we don't want to confuse ourselves. The palpation is last. Now we've done the active, passive and resisted movements. And now's the time to apply all the specific clinical additional tests of the specific joint that we're examining. So if we're examining the knee, we'll want to examine the McMurray's or the Lachman's. For example, the hip, we'll want to examine maybe for a Ferguson's test for an acetabular labral tear. The shoulder, we want to test for an O'Brien's test or a drop arm test to test for full thickness tear, The ankle, we want to test for maybe an anterior draw test to see if there's any evidence of ligament laxity, and so on and so forth. So now we've done the clinical examination, and we want to decide whether we should order tests, which tests to order, and if to order any tests. So first thing to rule out, are there red flags? Is there a progressive pain? Is there a change of mobility? Are there any of the other red flags that I mentioned earlier in the lecture? We want to rule out an inflammatory joint disease or autoimmune disease. We want to think twice before ordering a bone scan. First of all, a bone scan doesn't give that much information. It can tell you that someone has an osteoarthritis of a joint, of the hip, let's say. But it can't tell you if that joint is symptomatic or asymptomatic. If you're examining a patient and you see that that patient has very limited internal rotation of the hip, but elicits no pain at all, that osteoarthritis is asymptomatic. So you can often get much, much more information from a clinical examination than from the investigations that we do, such as a bone scan. And in addition, a bone scan gives out a lot of radiation. So we have to think twice, 3 times before we order a bone scan. Ultrasound, which is used more often, it's useful, it's cheap, there's no radiation, and we can often do it ourselves. We can often get clues to what's going on there. Is there any scar tissue? We can look at the tendons and see if there's any tearing there. Is there any tethering? We can look at it and see if there's any bone irregularity. And I've even often picked up fractures on an ultrasound. So ask yourselves, is any imaging going to change your treatment? And if it doesn't change your treatment at all, ask yourselves, do you really have to order any imaging? Maybe a wait and see approach is more applicable. Maybe you can do a trial of therapy of something and see if the patient improves before you go on to do imaging. And last but not least, we have to remember we're treating patients, we're treating people. We're not treating CTs and MRIs. And we should use our ears, our eyes, and our hands to examine patients. And patients are so much more impressed that we're taking notice of them. We're treating them and not a whole lot of paperwork. We should be systematic and go through a system to examine, to think of each structure that we're examining. And remember that even when you inject, that needle is an extension of your hand. When you put that needle in through the various tissues, you can get a feel. Is there muscle spasm? Is there scarring from previous operations, maybe? Is there calcification there? Is there a nitty-gritty feel near the joint? These are all cues that we can pick up if we put our minds to it, if we put our minds to what we're hearing, what we're seeing, and what we're feeling. So I hope that, thank you very much for listening. I hope I added something to your knowledge, and I hope to see you at some sort of practical course. Thank you for listening.